So here we are for the first Teabag episode. We have Derms and Conditions, the audio podcasts. We have Tea with Dr. D, the video podcast. And now we have the hybrid, which is called the Teabag. And what this is these Teabag episodes are a collection of questions that I've received from clinicians around the country or people with interest in dermatology from dermatology practices and answering these questions. But with the Teabag, you can either listen to it audio or you can actually sit down and watch it, and there are graphics that go along with it. And the first question today, which is actually from the recent Fall Clinical Dermatology meeting in Las Vegas, all of the questions that I'm going over today, I encountered from people either at the meeting or after the meeting that were there and that I ran into and asked me these individual questions. So the first question is, what are the comorbidities associated with hidradenitis suppurativa, HS? And this came from a presentation, a program, I believe the one that I had done at the Inflammatory Disease Summit with Dr. Mona Shariari. And when we look at the comorbidities, the significance of the comorbidities in hidradenitis suppurativa is that some of them are actually contributing directly to the development and the progression of the disease, like smoking and patients being of higher body weight, high body mass index, or even qualifying with their BMI as obese. But both of those are factors that we do want to try to get the patient help, but you can't necessarily address all of these things at the first visit, because the most important thing is to see the patient at that point in time, get a handle on their past history of what's gone on with hidradenitis suppurativa, get them to feel comfortable with you, because they've often gone to different clinicians that were uncomfortable with it because they didn't have much to treat it, or they didn't have much to treat it at the time and the patients gave up. So now they're back with you and you're the first time they're coming back to see someone in dermatology. To make a difference, you really have to connect with them and let them know you understand the disease, find out what's most important right there and then, and try to get them to feel comfortable, get them out of pain, get some lesions to reduce, and then you can work through some of these other areas. Smoking history and weight reduction are very important parts of it, and you may want to bring those up with them, but not necessarily get into it at the very, very first visit. It depends on the rapport with the patient and what they tell you. Now, the other comorbid conditions, these appeared in the Lancet in February 2025, a great article. The risk factors above appeared in Frontiers of Immunology in December of 2018. But this particular chart, I think, is extremely important and one that you might want to take a screenshot of or go to this article. It's open access. It shows you the other conditions that many patients with hidradenitis suffer from, and they're going to be very important to be addressed for their overall health. Obviously, many of them may be depressed associated with the disease. Some of them will be diabetic or have problems that are related to metabolic syndrome, cardiovascular disease, even inflammatory bowel disease. And in terms of intimacy and sexual dysfunction, they may have a sexual dysfunction, but a lot of it could be because of pain and embarrassment associated with the hidradenitis that they're having the difficulty having any type of sexual encounter. It's an extremely painful and difficult disease because of the location of the lesions, the severity of the lesions, and how painful they are, and also having discharge, malodor. It goes on and on. So addressing these things is very important to be aware of them, but you're going to be selective in how you integrate this into the management. You're not going to be able to do this all at the first visit. Making the patient comfortable with you and getting them comfortable with the disease, to me, is the first step. So now let's move to the next question. And the next question relates to hidradenitis suppurativa, and it's a very, very relevant one. How do you determine when to initiate biologic treatment for HS? And it's a major clinical challenge, and I'd like to bring up a graphic which appears in that February 2025 Lancet article. And there's a picture of the article on the right. It's available for open access. And what you're seeing here are the three phases of hidradenitis suppurativa as lesions are developing. Lesions will start in an inflammatory phase, right? You'll have abscesses and nodules. Then they'll go into that middle phase there, a destructive phase. Now you're starting to get sinus tracts. You've had rupture of the follicle. You're starting to get the formation of inflammation leading to scar formation. And then you had the third phase, which is burnout, where all the inflammation in that particular area is pretty much resolved. It's minimal. Now you have scars and sinus tracts where you're really at the end stage of what's happening. And this could be starting and stopping in different anatomic locations because the patients have multiple lesions. Where I put that octagon, that red stop sign, is really what correlates with the old Hurley staging, where stage one, they had, they were milder, they had some inflammatory areas, but they didn't have any scars or sinus tracts forming yet. And then the destructive phase is the phase two. And we used to talk about really getting involved with biologic agents and going after the disease in that destructive phase. Well, it's too late in those areas. So if that destructive phase has had time to progress, the patient's already getting scars and sinus tracts, and they're on to having irreversible lesions because of the burnout phase. If you go to the next graphic, what we're seeing here, where I put those green stars, this is where we really want to initiate the biologic therapy, to whether it's adalimumab, secukinumab, or bimekizumab. There's data on all three of those agents. I think the anti-IL-17 agents, the two latter ones, have advanced in terms of, in my mind, the ability to get the disease under better control. That's my own personal opinion. But all three of them are FDA approved, initiating earlier before we already have scars and sinus tracts that are becoming fixed. So you actually see that on the right-hand side, that red box, we're not waiting to get further on into the destructive phase. And then the burnout phase, it's too late. The biologics are not going to turn around a fixed fibrotic sinus tract or a scar. That's going to be too late. And you can continue to use the biologics. The patients may have painful areas that are related simply to the fact that it's a scar and it needs another type of intervention. So keep this in mind, and it's very important to initiate the biologic agents as early as possible so we can stop what's happening underneath the skin, beyond what we can visibly see. The next question I'd like to look at is, what about beyond biologic agents for hidradenitis suppurativa? There was a lot of interest. I got this question both at the meeting from some people and after the meeting. So there are two ways to look at that. You're utilizing your biologic agents. You may have some topical agents you use, some antibiotics that you've given the patient up front, but you're not going to recycle them just on antibiotics. You want to get that biologic therapy, which is so much better in terms of reducing abscesses, nodules, and the progression to sinus tracts and tunnels that are discharging exudate. We're trying to stop that. But during the course of the disease, you get focal areas that are very inflamed, very deep abscesses, and then can be forming fibrosis or developing an inflamed tunnel that's discharging, even purulent exudate out of its opening on the surface, often a double comedone. So there are two ways to look at if the patient has an isolated lesion, an inflamed cyst that's very painful. Yes, you can use intralesional therapy, intralesional triamcinolone. But for these deep-seated lesions, it's much higher than the concentration you would use, let's say, on the face. So you're using anywhere from 20 milligrams to 40 milligrams, gently palpating the area, applying some ice, use some topical anesthetic because it's going to be painful, and actually do the intralesional injection. If you have an inflamed cystic type area that's very painful, you can do an incision and drainage that you have of that abscess, not necessarily to fully treat the abscess, but to relieve the pressure. And the incision really is best done not with an 11 blade, because that's going to close up very, very quickly. Use a 4 to 6 millimeter punch that will remain open, eventually heal by second intention. That will allow that area to continue to drain. So these are two office procedures you can do to try to reduce pain and swelling that can be really, really helpful for isolated lesions, right? That the patient is pointing out to you. Always ask them to point out painful areas. The next slide talks about deroofing. This is a little bit different, okay? Deroofing is when you have a tunnel, right? The skin overlying a tunnel, sometimes an abscess, where you're going to make an incision, unroof that, remove that skin on the surface, and allow that area to drain. And there's lots of good videos to do that. Sometimes this can be the problem that takes the patient out of partial improvement with biologics to now having more complete improvement because you're removing these lesions that are more persistent and are painful for the patient. Now, excisions of the entire area when you're really in the burned out phase and they're still maybe forming some lesions, that's a different story. That's something that you're excising the entire axilla or the groin area down to subcutaneous fat. That's done under general anesthesia. That's rarely needed anymore if we initiate treatments early and we do things like deroofing and intralesional therapy. The next question was about photodynamic therapy and non-melanoma skin cancer. And the individual that asked it wanted to know more about something that has been recently published, and we do have a graphic here that talks about an article, Red Light Photodynamic Therapy with 10% aminolevulinic acid gel for the treatment of superficial basal cell carcinoma. And it was actually a randomized vehicle-controlled trial, double-blind, multi-center phase 3 study, utilizing 10% aminolevulinic acid gel and red light, either one or 2 sessions. And I can tell you that when you're treating conditions, in this case superficial basal cell carcinoma, but I also remember treating squamous cell carcinoma in situ, these are superficial lesions that could go on forever. And in the case of Mohs surgery, you're tracking wider and wider and wider. It's really hard to get to histologic clearance on those lesions. So it's nice to have therapies that you can actually treat beyond what looks like the visible area, or even microscopically, going to go beyond what the margin of the lesion visibly, microscopically, it can go beyond that. So what they did here is they had lesions that were at least 6 millimeters, often more. Most of them were on the trunk and extremities, not many on the face, and they found target areas, though all the lesions could be treated. And so what you're seeing in the graphic is the clinical clearance, the histologic clearance, because the target areas were excised for the purpose of the study to see if there was complete clearance, and how often you had both clinical and histologic clearance after 1 or 2 sessions of utilizing the 10% ALA gel and red light photodynamic therapy. The incubation period was 3 to 3.5 hours, and they had 1 to 2 treatments. And you can see here the efficacy of the red light therapy with the 10% aminolevulinic acid gel for superficial basal cell carcinoma was substantially better than in the group that had used the vehicle without the 10% aminolevulinic acid. And the cosmetic outcomes were very, very favorable. Obviously, it can be painful. You have to manage the PDT as you would otherwise. But I think this adds a lot to the literature, and you may find it useful if you utilize photodynamic therapy in your practice or are considering using it for superficial basal cell carcinoma. It was published in the Journal of the American Academy of Dermatology. So the next question I received, actually after the meeting, I was contacted by a few different clinicians, is about the topical nonsteroidal therapy for lichen planus. And I had presented two different publications. The first is in Skin, the Journal of Cutaneous Medicine, which is open access, so you can get access to this article and print it out, in July 2025, and it's by Soto Canetti, Lichman, and Jordan Talia, right? I know Graham Lichman. He practices here in Las Vegas, a great guy. We work a lot of on different things together. He was also one of Darrell Regal's fellows, melanoma fellows, and then went on and did his residency in New York with Suzanne Rosenberg. Great guy, and I think this was a very, very important publication with regard to cutaneous lichen planus. Topical roflumilast, which is under the brand name of Zoryve, for the treatment of cutaneous lichen planus, and this happens to be in a Hispanic patient. And what you're looking at in the photographs here, if you could see the photographs, but you're seeing lichen planus lesions on the distal legs and the feet, and the patient had been treated initially with triamcinolone cream and also, I believe, some hydrocortisone cream, had utilized some topical corticosteroids, and didn't get better. They were having a significant amount of itching, so they decided to utilize topical roflumilast, which is not FDA approved for lichen planus, but thinking about the mechanism of action being a phosphodiesterase 4 inhibitor, it can have a spillover into modifying some of the cytokines, and in this case, type 1 interferons that are involved in the disease, because phosphodiesterase 4, being an intracellular enzyme, affects a variety of different potential pathways. And lichen planus, it could be potentially one of them. Well, at least in this patient, they saw that the patient had a rapid improvement as compared to what they achieved before. And as you can see in the photograph, within 5 weeks, the patient was substantially improved, and then had even further improvement where they had the sustaining of that initial improvement over 6 months. And that's using roflumilast 0.3% cream once a day. So I think that's a reasonable thing to try. This is a very effective medicine where it's indicated for atopic dermatitis, seborrheic dermatitis, and plaque psoriasis, but we're seeing a lot of case reports with applications to other areas. And lichen planus is one where we now have case report, and I know of other cases that have been effectively treated with topical roflumilast. So it is something to consider. I think the safety profile and the tolerability profile speak for themselves, so I'm not really concerned much about that in this particular situation. Right? The next paper is from the Journal of Investigative Dermatology, reported in 2022 by Brumfield, and there are other authors there. And this looks at ruxolitinib cream, which is Opzelura, in the treatment of cutaneous lichen planus. And they did a prospective open-label study that they also looked at transcriptome analysis. So this is a Janus kinase inhibitor that is FDA approved for atopic dermatitis and for vitiligo, and it made sense for utilizing it lichen planus because it would have an effect on the interferon-driven disease, the cytokine profile that has been seen to be present in lichen planus. And they had a small study of patients that they treated for 8 weeks. You're seeing here pictures on the right. If you look at the photos that are included in this article, you'll see that the photo that is designated as A is at week 1, and B is at week 7, lesion being treated with topical ruxolitinib. Okay. And what you're seeing there is the difference between week 1 and week 7. So you see a reduction in the inflammation and you see some resolution of the hyperpigmentation over time. And then you see picture C, which is at week 1, and then picture D, which is at week 7, you see that those lesions, the reduction in inflammation and the progressive decrease in hyperpigmentation. So I hope you found this first Teabag valuable. I think it would be most valuable if you actually watch it with the graphics, but I also believe if you're just listening in your car, like many people do, with terms and conditions, you can hopefully get a lot out of it. Thank you very much and enjoy.